right up there in our face. Yeah, it's visible to all of us now.
Yeah, I think the Delhi one also last 6-7 years I've been in Delhi. Earlier when we were kids, it used to come in like July. Now it's like September, August, and the rains.
Absolutely, absolutely. Better put my phone on silent, otherwise it's going to ring at all the awkward
Mr.
moments.
Rajpaksha, I think you will probably on the below bar, we'll have this interpretation. I think there's an English one that we need to select so that then the interpretation can happen in Hindi and Pashto concurrently, and we'll have to mute the original audio. I think there are two, if you'll click on it, you'll see two menus on it. So just click English and mute one. I think that should
okay, I'll do.
Good morning, Dr. Nusrat.
Hi, Dr. Vikash. Should I keep my video on or shall I keep it off because so the panelists can be seen? Dr. Vikash, what should I be doing?
No, so you just click on English, that's all.
No, this is regarding the video.
You can switch on your video.
Sure.
Because from my side, Drishti is a little unwell, so she has excused herself and she won't be joining.
Sure.
I will try and respond to any question that come in.
Sure.
Hi, Nusrat.
Hi, how are you?
Good, good. How are you?
Good, good.
I was just thinking we can start around 10:01, Indian Standard Time, because sessions are generally very packed, so we can then finish or both the presentations, have a good time to discuss and stop the session by 11:20 IST. That was, I think, in any case, there's a hard stop there, so it'll give us a good time, and we can start as soon as it becomes. Probably wait 1 minute and then start at 10:01. Sure. I hope that's fine. Yeah. Mr. Rajpaksha, I'll introduce, I thought you weren't there when I was telling that I can introduce these, I'll introduce the session and then introduce Amita. And the first presentation will happen. After her presentation, then I'll introduce you and Dr. Nusrat and then your presentation, and then we'll have a discussion for like 10-15 minutes. If you're comfortable sharing the screen for the presentation, that's absolutely fine, because that feature is activated for you. But in case there is any technical glitch, I can project it from my end. You can let me know when the slides need to move, whatever you feel comfortable with.
Okay, we'll say how it's our lesson, right?
Sure, thanks.
Dr. Vikas, I'll be coming for the discussion part. I think it will be better if I keep the camera off. No, otherwise I don't know whether it will be distracting.
Sure, sure. That's perfect. That's absolutely fine, Dr. Nusrat. I think that's a good idea. Maybe we can all switch off when the first presentation starts, and then once Mr. Rajapaksha is presenting, and then the question hour session, then we can all have our videos on. I'll then just remind everybody to have the videos.
Thank you.
Okay, I think we can start now. It's 10:01, and maybe for keeping the time and all the things, it might be good to start the sessions, and we'll keep having participants join the sessions. Hi everyone. Good morning, good afternoon, good evening, wherever you are in the world. We're so glad you've joined us today for this exciting session on SRH service delivery for apparel workers, titled Needles, Thread and SRH. Our session today will focus on the the sexual and reproductive health needs and rights of apparel sector workers in India and Sri Lanka. The session will focus on the SRH needs of the workers and why is it important from the SRH perspective to be able to provide services to this population, which is particularly vulnerable. The two presentations will include the journey and exclusive initiatives taken by Family Planning Association of India and Family Planning Association of Sri Lanka, respectively, in addressing these needs. Finally, the session also will discuss around the various challenges during service delivery over the last few years, and we are going to focus a little bit around the issues that presented during COVID-19 and what were some of the mitigation strategies that were employed at the ground level for the service delivery. Our first presentation will be from Ms. Amita Dhanu, Assistant Secretary General Program Implementation at the Family Planning Association of India. Ms. Amita is heading the program team at FPA India, holding the position of Assistant Secretary General, and she's a master's from sociology from Delhi School of Economics with diploma in business management from Mumbai. She has a rich 28 years of experience in FPA India. She's been initiating several projects, managing programs in sexual and reproductive health with a focus on adolescent, women empowerment, and HIV/AIDS interventions. She has worked as a director for a project from 2004 to 2012, which addressed the issues of sex workers and helped improve their health-seeking behavior. The project was part of the India AIDS initiative of the Bill and Melinda Gates Foundation being implemented by FPA India in partnership with FHI 360. Prior to joining the development sector, she worked in the field of advertising for 7 years and was also a lecturer in sociology in SNDT University, Mumbai. Without further ado, I hand it over to Amita to help us through the understanding what are some of the special needs of this apparel sector workers, for specifically focusing on SRHR, and how did FPA India deliver services before COVID and during COVID. How was the journey with respect to service delivery? The floor is yours, Amita. Over to you.
Thank you so much, Vikas, for this wonderful introduction. I have a few slides that I have put together, and maybe that can set the context. And I'll be happy to respond to any questions or any clarifications that anybody would need after the presentation. Thank you so much. Allow me 2 minutes to get my presentation going.
Sure, Amita. Thank you.
Can you all see the presentation?
Yes, we can. We can.
Yeah. Okay, so just give me a second to make it into, yeah. Thank you so much. So to begin with, the project that we have titled is called Happy Workplace, Healthy Workplace. And this is a project that is supported by the Levi-Strauss Foundation.
Hello, doctor. Hello.
Hello. Yeah.
Can we have mute buttons on? I think that otherwise it disturbs the presentation. Thank you.
Okay. So just to continue, the goal of the project has been to make quality SRH information and services, including preventive health services, available and accessible to women and men garment workers. So the profile of the workers in India is that, while yes, primarily we have women workers, but there is also interspersed with men workers in the factories. And of course, the long-term goal is that health-deprived women garment workers are aware about their SRHR and lead stigma-free, healthy, and productive lives in a safe and enabling environment. So this is the larger context in which we had commenced our project. Now, the locations where this project is being implemented is Bangalore, Bhiwandi, and Sholapur. Now, I'm just giving you a little context of how many factories we are working with and, when did we start the intervention. So we started work in 2018. Primarily we started work in Bengaluru and Bhiwandi. And in Bhiwandi, the factories are slightly different. They are basically loom workers who are manufacturing the basic cloth. And in Bangalore and in Sholapur, where we are also working, is primarily manufacturing the end product, that's the garments. And in Sholapur, where we are working, it is known as the global hub for manufacturing uniforms. Now the uniforms can be for school children. It could be for for hospital staff, or basically all kind of uniforms are being manufactured in Sholapur, which is a tier 2 city in Maharashtra. Now, these are just some stats to show you that, how many factories that we are working with. And in 2020, we have concentrated work in only Bangalore and Sholapur. And a total of 106 garment factories have been identified, and approximately 32,000 plus workers are associated with these factories. And for this phase, we are kind of expected to reach out to about 19,000 plus workers. And now we have already reached out about 6,000 plus now in the first 6 months of the project. Now, obviously, before we started the intervention, we had to understand what are the basic needs of these women and the men working in the factories. What is it that we need to really do to make the package more tailor-made to suit their needs? So what we understood was that largely in all these 3 locations, the garment workers are basically migrants who have moved from either nearby villages or even from some distant villages, primarily from the northern part of the country, which is Uttar Pradesh and Madhya Pradesh. So where there is abysmal poverty in these states, and people have moved from there to come to Bangalore, to Bhiwandi, and to Sholapur, which are the southern parts of the country. So they have actually moved there. And typically they live in clusters, which is close to the factories, but they decide to kind of live together, sharing rooms. So one room would probably have 7 or 8 women or 7 or 8 men living together. At the workplace, the working conditions are very poor. They have long working hours. In some places, the women have to stand for hours together, as the men as well. And they only get respite to sit down during the lunch breaks. But this is not the case in all the factories. In some factories, women are expected to sit and stitch the garment. So therefore, there's a difference between manufacturing the basic fabric, the cloth, and when they're stitching the garments. Of course, there are no paid leaves. The wages are low. These were some of the common issues that we identified. And because of the long working hours, they are unable to access health services from clinics, either the government or the private facilities. Now, there was high prevalence of anemia and malnutrition were found among particularly the women workers. Other health issues are probably related more to the occupation, like dermatitis, early vision and hearing complaints, musculoskeletal complaints, insomnia, etc. is what we found. Typically, and which was not very surprising, that the knowledge about sexual reproductive health was very low. They had some information on menstruation and pregnancy, but have absolutely no knowledge on contraception, safe abortion services, STIs, HIVs, infertility, or even reproductive cancers. They were not aware that safe abortion services in our country is legal, and they would be resorting to going to clandestine providers and practicing unsafe abortions. Their health concerns also arose because, and this this was more visible in our study from amongst the men who have multiple sex partners, and this was particularly visible in Bhiwandi, where there is a brothel right in the midst of the area where these loom factories were. So what were some of the quick strategies that we worked out? One, of course, as is logical, that we had to work with the factory managers and the owners. And what really melted the ice between them was that we said that the services will be provided to not just the government workers or the shop floor workers, but also to the managers themselves and the administrative staff that they had. So that became a little bit of a, I mean, this is a very small thing, but this helped them to also, become a little more receptive towards our services. We had to work with the government health workers as well, which are the ASHA workers, or what are called the frontline workers of the government, because sometimes if we are not able to reach the residences of the factory workers, the government health workers have been trained to be able to provide them with some basic SRH services. We had to work with the law enforcement authorities as well, particularly with the police, because very often the government workers, while traveling back, are coming back home late in the evenings, late in nights, and there was harassment by the police. So we had to work with them as well. And of course, as I've already said, and this whole project is around providing health sessions in the factory premises. That is the whole idea of a workplace intervention. Now, while of course we did have a lot of information sessions and delivery sessions there, what we also found was that they were the workers are very receptive when you engage them in, let's say, entertainment activities linked to the SRH messaging. So we have had a lot of games with them, quiz contests with them, which has made kind of, helped in their being a little more, being able to understand our messages better, rather than just a very didactic method of standing up and giving a lecture. Of course, the entry point for any SRH services, whether it's in a community base or at the workplace, has to be general health concerns. So you have to address the general health issues, whether it is a stomach ache, whether it's a headache, or body pains that we use as an entry point before we're able to start discussing SRH issues. Another strategy that we have used is that we have created a cadre of peer educators who are based in the factories. And sometimes these peer educators, because if they're living together in the same area, are able to provide services in the at homes as well. So these, if you would see that these have been some of, sorry. So if you will see that this is largely the way we have operationalized the project, and I'll be talking about each of these strategies a little later. Yeah. So for demand generation, this was after for demand generation, obviously we needed to create an awareness amongst the factory workers on basic SRH issues, whether it was menstrual hygiene, whether it's unprotected sex. So we had to create a lot of awareness, because as I said, there was absolutely no information available with the workers. So we have a team of outreach workers who mobilize the factory workers to come and attend the sessions, which are typically conducted during the lunch hours. And the sessions are conducted by our FPI counselors and also by the doctors who are there when we have the health sessions. Now, due to the COVID-19 restrictions, emphasis is also given on distribution of information leaflets in local language on various SRH topics, because, which I will come to a little later, that, very often during the COVID times, there was restrictions on entry of our teams into the factories. So we had to give out leaflets which were self-explanatory for them to be able to read and understand some issues. We have several job aids which support these sessions, and these are on multiple SRH issues, as you can see up there, comprehensive abortion care, cervical cancer, and so on and so forth. And these have been printed both from the FPI sources as well as from the Ministry of Health. Now, service sessions in the factories. Typically, we have a team which goes out into the factory, which comprises of the doctor, the nurse, the counselors, lab technicians. They go into the factories. And what we're seeing over here is the range of services, but not all of these are available in the factory. We also have referrals to our own, FPI static clinics and the satellite clinics, which I will talk about a little later. But these are the range of services that the government factory workers are able to get access to. So history taking is one of the spaces we're able to spend more time in understanding what are the specific needs, what have been the sexual behavior patterns of the sex workers. And also particularly, this is the space where we're able to talk about any gender-based violence that the woman, particularly the women, are undergoing. So this is the space we're able to talk about. And of course, we then link it up to the counselor who takes these ahead. We have also provided referral services, and particularly I'm talking about safe abortion services that have been accessed by the women, which you see up there. It's about 134 women have accessed safe abortion services. While we do have these specific, factory-based services, which we have already, I've just mentioned about, we've got women care centers. Now, women care centers are centers that are, based within the busy areas of the factory, and where it is that, factory workers from multiple factories can come in. And this operates once a week. And this is at, I'm talking about Bangalore, sorry, I didn't mention that. But this is functioning like a satellite clinic where the complete team is available, because if you're not able to reach all the factories in a given week, so this is one space where they're able to come and access services. The demand from the workers is now also coming up that we need to expand our services to treat dermatology related issues and treatment of non-communicable diseases. Particularly the cases are coming up for hypertension and diabetes. So there's a demand that we also get specialist doctors for providing services on these issues. Also, they're talking about, mental health issues, particularly a lot of stress and tension, which is linked to multiple factors, primarily because of COVID. There have been, loss of wages. People have been, factories have shut down, and I will talk about that a little later. So they're talking, they need a lot of mental health support services as well. In Sholapur, our own FPI clinic, or what we call as the reproductive health and family planning clinics, are very, very close to the area where we have the garment factories. So we have dedicated a day when they can come and access advanced services from our own clinics, apart from what we are already providing to them in their factories, which has its own limitations. So this has been the service delivery model. So we are able to provide them services in the factories, through the FPI static clinics, through the women care centers, and of course, for advanced care, they're referred to our own FPI centers and to the associated clinic that we have partnership with. Another model that I wanted to really talk about is the peer education model. Now, the peer education model has turned out to be very effective. We have just created this cadre, and they have received training, and they are still being trained actually. But we have got certain criteria on the basis of which we select these peer educators who can obviously communicate better, who are interested in doing this, and they're willing to coordinate with the FPI teams when organizing the service sessions in the communities, and of course being able to talk to the other garment factory workers during the off time also. So we have got a model where we have roughly about 2 to 4 peer educators per factory, depending on the number of factories in that the factory we have. So far, we have trained about 67 peer educators in this given duration. We have given them certain toolkits, certain reference books which they can refer to, which includes frequently asked questions on all of these topics. And they also carry condoms, emergency contraceptive pills, pregnancy testing kits for distributions amongst the factory workers, amongst their own peers. What we also found interesting was that, rather than just talking about SRH issues on a regular basis, they're also very receptive when we have, dedicated days. We all know about World Contraception Day, Safe Abortion Day, Menstrual Hygiene Day. So they are very keen on attending these special day observations, where we call in specialists to come and talk about various issues. And as I mentioned earlier, we organize competitions after these talks, which they find very interesting. And obviously, we kind of felicitate them, give them small prizes, which they find very motivating. Now, coming to the most important part, and that is, of course, how has COVID-19 impacted on our work in the factories? Now, this has been absolutely a gendered, disproportionately gendered push, where the women have been pushed to go back to their own villages. Factories have closed down, and they have gone back to their traditional roles of working basically they're coming in from the rural areas where they're working in farms, so they are being compelled to go back to the farms and work on the farms. And also, only very few factories provided residential facilities for migrant workers and facility of creches for children between 3 and 8 years only. Now, in under the Indian labor laws, factories that employ more than 30 women have to provide a creche for children under 6 years. But with this COVID restrictions, factories have shut down these creches, leading to problems for the women. Where do they leave the children? How do they work, balance their work and their the family lives? So this has been a bit of a challenge, and there's no clarity when these creches might even reopen. A lot of workers have just lost their jobs and not being paid their wages, and they have had to borrow money, and they've run into huge debts. Most factory owners did not provide any kind of assistance to the workers and left them to fend on their own. And they have had to go back to their villages, as I mentioned earlier. Now, what did FPI do to respond to this pandemic situation? We launched our telecounseling and teleconsultation services to provide a continuum of the services. Now, not that we were not providing services on the mobile phones earlier, but this is an opportunity where we really strengthen our work. And this is not just limited to the Levi-Strauss project, but across our 40 branches. So we branches have got dedicated number to provide digital health services, and these could be with the doctors or the counselors after getting their due concurrence. Or there could be a number that is kept during working hours in the clinic itself. So we have different ways in which we have provided this information to the communities. We have created WhatsApp groups for each factory, and the numbers are shared, and sessions are conducted on the WhatsApp. We kind of pick up topics for the week, and we talk about that topic on the WhatsApp, give them information on the WhatsApp groups. And of course, the telecounseling services have benefited hugely for the men themselves, because men who were shying to come to services for availing services during the factory hours, because predominantly there would be women there for the existing services, they found telecommunication or telecounseling very, very easy, where they were able to open up and access services. I just wanted to briefly talk about an app that we had developed now with the support, pro bono support from an American-based company. And this was basically in the early times of the COVID, that was in 2019, where we had got this app going, which was basically an app for recording the temperatures of clients before they enter the static clinic or the satellite clinics, or also on the shop floor. And it was basically to recording of symptom-based screening and contact screening. It had an algorithm to decide if a person is COVID suspect. And based on the outcome, there was referrals given to the Government of India facilities or the service delivery clinics, that was our own FPI clinics. And this helped in a faster data entry. There was electronic medical records were generated, and there was an automatic report generation. And this was linked to the FPI system of the electronic CMIS. Yeah, there have been huge challenges, which is not just limited to the COVID times, but primarily during COVID, it got even increasingly more difficult, where the the factory managers were not giving any permissions for outsiders to enter the factory premises. A lot of workers had gone back to the villages, as I mentioned earlier, and it became increasingly difficult for us to track them for follow-up services. And also the workers themselves were afraid to avail services during the second wave of the pandemic. And generally, of course, there are huge amounts of myths and misconceptions about family planning and contraception, which are typically the same as when we have community-based or rural-based interventions about IUD insertions, whether it is about abortion services. So they have a lot of myths and misconceptions. And also this whole concept of rights-based information or rights-based services is something that the garment floor factory workers have not been able to really understand as of now. They do not understand the concept of rights-based. They are always in a mode of being obligated to FPI or to the factory managers because they have been permitted to come into the factories, and they do not understand the concept of demanding for services from the factory managers or demanding for their rights. So, which is completely understandable. And of course, the usual complaint of the FPI teams do not get adequate time, and they have to find the time around it to provide the information and the services. I don't know why I'm not able to move the cursor now. Yeah, sorry. Yeah, so based on our work over the last year and a half, what we are seeing that GBV screening services are being provided, but we need to now assess a little bit more on the sexual exploitation of garment workers, especially the women workers. We have a lot of anecdotal evidence that is coming up that the shop floor managers are kind of sexually harassing the workers, but nobody is willing to, as of now, come up and talk about the exploitation. And we completely understand this is also as a result of not having adequate time for counseling. Obviously, these things come out more during a counseling session. And because we are in a rush in the providing services on the shop floor, in the factory premises, that it becomes a little difficult for us to be able to really probe into these very sensitive issues. But we are working out a strategy of how do we really be able to ascertain without upsetting the factory managers. So it's a little, if I can say, a little sensitive, but we are trying to see how best we can do this. Also, this whole concept of, also this whole concept of sexual orientation, sexual behavior is something that is nobody has ever really discussed these issues with them. So slowly they are opening up, and we are looking at certain, I mean, I'm not too huge a number, but some indications of lesbian relationships or men having sex with men are coming up, and we would be now building our work around these issues to how to address them in the factory settings. Also, we saw that it's important to address occupation health hazards or occupation linked problems. For example, there's a lot of noise in the factories, particularly in the power looms. And we have recently just kind of discussed with the factory managers that is it possible for them to provide them with rubber earbuds? You have these industrial earbuds, if those could be provided, which of course the factory managers are thinking about it. They haven't really provided them as yet, and we are wondering if we could do it as a part of the project ourselves, wherever it's feasible. Because this is leading to a lot of problem. They're losing their the hearing capacities getting reduced and diminished, and leads to increased headache. So we are talking to the factory managers if this could be possible. And we are now also realizing that we need to have probably dedicated days in our own RHFPCs, in our own clinics, where the men can come and access services. These are some case studies about how factory garment workers have benefited. This is a case of a woman who had a husband was a truck driver, and he was also an alcoholic, and he had unprotected sex with her. And she became pregnant. She didn't want to continue with the pregnancy, and she tried to induce the abortion herself, but it was incomplete abortion. And then she was informed about the FPI services by her factory colleague, and she contacted the outreach worker, and she was then given the complete services, and she was counseled about using contraceptive and how to address GBV issues. And she is now keen to become our peer educator in the factory that she's working in. Now here, this is the case of another garment worker. Her husband is a truck driver. He doesn't stay with Priya because of the nature of his job, and she takes care of her 3 children on her own. But since a few days, she was complaining of pain in the lower abdomen and white discharge while urinating, and she also developed rashes and blisters around the genitals. Her husband came home for a few days, and they had unprotected sex again. And as she was aware about the services being provided by FPI at the factory, she came for availing treatment in the medical camp. She was counseled about the STIs and provided appropriate treatment for STI management. She has been counseled on partner treatment and consistent condom use. So these are just a couple of case studies that I have shared with you, and some photographs to show the kind of factories and how the services are being provided within the factory premises. And of course, there's been a lot of press coverage, which I've not been able to show here. There have been chat shows on the television, particularly in Cholapur branch. So they have used the media to really talk about their services or the project being implemented by the branch. Thank you so much.
Thank you, Amita, for walking us through the entire model and showing how FPI is also thinking about the entire prevention to services continuum in this model. I think there's been demand generation activities, the challenges of COVID. As we know, it was the biggest disruptor. So that has, I guess, for all populations, and particularly this population, would have disrupted the services, and the SRH needs for them would have just heightened, I would believe. I have a few questions for you, Amita, but let's park them for right now, and we can have that after the presentation from Rajapaksha ji. And I would like to now hand over the presentation to FPASL. I'll just give a little bit of an introduction to Mr. Pradeep Rajapaksha ji, who is the ex-director of the outreach unit at FPASL, and he had been ex-director from 2016 to 2020. He's currently working as a consultant of the outreach unit at Family Planning Association Sri Lanka. Mr. Rajapaksha joined the organization in 1990 as a district project manager and became the director in 2016. He has over 32 years of experience. That's like a wide, rich experience that we will be listening to and hopefully learning from in the field of sexual and reproductive health, deep knowledge of managing SRHR projects in humanitarian settings. He has worked as a development officer for 5 years with the local government department in Sri Lanka and attended various workshops and training in the field of SRHR. He holds a Bachelor of Arts special degree in Geography and Master of Sociology from the University of Kelaniya, along with a higher diploma in International Relationship from the Bandar Naike Center for International Studies. I would also like to say that after the presentation during the question hour session, he will be Dr. Nujrat, the Deputy Medical Director at Family Planning Association of Sri Lanka, who oversees the sexual and reproductive health and service delivery at FPASL, would also be joining us for the discussion. And she has also been working in this field with the Ministry of Health and with the private sector in Sri Lanka for the past 7 years. She is a graduate from Manipal College of Medical Sciences with Bachelor in Medicine and Surgery and postgraduate in Venereology from the University of Colombo. Welcome, Mr. Rajapaksha and Dr. Nujrat. I hand over the floor to you for your presentation. Thank you.
Okay. All right. Wait a minute. Hello. Hello. Hello.
Hello, Rajapaksha ji, we can hear you. Please go ahead.
Can you hear me? Yes.
Yes, we can hear you. Please go ahead.
Dear Vikas and all, very good morning. I welcome all of you for this presentation, and thank you very much for your wonderful introduction about me. I am really happy to be part of this presentation, and really thank you for giving this opportunity to present in Sri Lankan apparel sector workforce SRH issue. Before move to my presentation, just I want to tell about objective of my presentation. Through this presentation, I present to provide a brief outline of the sexual and reproductive health and issues of the apparel sector workforce in Sri Lanka, as well as a little bit. I would like to explain a little bit about the specificities of the address of SRHs and the challenges we encountered and we faced during the service provision. Before go to my subject, just I want to tell something about my association FPS Sri Lanka. FPS Sri Lanka is established in 1953 as a non-governmental organization, and 1954 we got the IPFF membership. And under the Family Planning Association, we have 6 unit, outreach unit, medical unit, social marketing program, advocacy program, and finance unit. Out of those units, outreach unit was the most the oldest unit in the Family Planning Association, established in 1978, and all the outreach sessions were conducted through by the outreach unit. Under the outreach unit, we have, this is the Sri Lankan map. Sri Lanka divided into 25 district, administrative district, and also 9 provinces. Out of 25 district, as Family Planning Association, we covered only 6 districts. We have 6 service delivery different locations in the district. Our 6 SDPs are located in 6 districts: Colombo, Gampa, Galle, Batikolo, Nuwara, and Ampara Suwaseva. One is the Ampara Suwaseva Center, and second is Batikolo Suwaseva Center. Third one is Kokkal Suwaseva Center. And we have another service delivery point, Nuwara, and Sitaok and Watupitiwela. Out of these 6 service delivery points, 3 service delivery points located within the PTS zone. One is in Koggala. This is we started that 2009. This Koggala Suwaseva Center. It is located within the PTS zone, and Sitawaka Suwaseva Center, that's also located in the VOI in the Sitawaka, and we have another service delivery point within the PTS zone in Watupitiwela. Our target beneficiaries of each centers, Ampara service delivery point, we cover mostly poor, marginalized, underserved, and socially excluded community. Most we cover in Sinhala people and Tamil and Muslim community. In Batikolo service delivery point, we covered our beneficiaries are poor, marginalized, underserved, and socially excluded people. Especially, we provide our services for Tamil and Muslim community. Kokkala service delivery point, especially we cater to the apparel sector workforce, and also we provide our services for marginalized, underserved community through the Kokkala service by Kokkala service delivery point. Nuwara service delivery point especially cater to T estate community. All are from T estate. They are the Tamil community. And Sitawaka service delivery point, we provide services for the apparel sector workers, and also Watupitiwela service delivery point, we provide services for the apparel sector workers. The number of apparel sector workers in Sri Lanka. Just I want to elaborate how many. There are 14 BOI zones across the country. And total workforce is 100,042, 653 work populations under the 14 BOI zones. When we take as a male and female, there are in 78,642 male workforce and 64,011 in female workers. This is the number of beneficiaries. Koggala Service Development Week, there are 12 factories, garment factories. Most of them are in apparel sector, garment factory. In Koggala, there are around 12,670 work population, and male 3,258 and female 9,412. As a percentage, 25 were female and others are male and others are female. Sitawaka, there are in 26 garment factories. The total work population are 25,749, male are 13,262 and female are 12,487. In Watuputtuwela zone, there are in 17 garment factories. Total work population 9,603 and male 3,748 and female 5,858. Those are the number of population we covered under these 3 service delivery points. Now I want to explain the need of the SRH service for the factory workers in Sri Lanka. Here I will like to explain the reason for why we need to address SRH issues of the factory workers. In Sri Lanka, mostly sewing machines are mostly operated by women in Sri Lanka. Sri Lanka age for employment in 18 years. Most of the apparel sector workers are young, age cohort is 18 to 30. The majority of the garment factory workers are women, age 18 to 35, and then most of them are reproductive age, accounting for approximately 75 of the workers are female. Most of them have only a basic educational background, lack of SRH skills and SRH knowledge. During our service position, we could identify most SR issues among the female workforce. Women face a variety of challenges when they come to work at the factory and also boarding rooms, and while traveling, they face many challenges. Most of them related to the SRH. And women are also more vulnerable to sexual abuse and rape. And most of them are internal migration. They are from far away places to the urban town. Most of the factories BO zones located in Colombo. Colombo means in the urban. And when they come to the urban, most of them are unfamiliar with the environment. That's also cause for the sexual issues. Issues with lodging safety. Most of them doesn't have a specific boarding place. They reside in rooms and rented rooms and hotels. That also leads to sexual harassment and sexual issues and rape cases. Working hours. Usually in factory, workers work around 16 hours per day, and sometimes they shift off in midnight. That also lead to the sexual problem, unsafe sexual relation. Most of them have unsafe sexual relationship. And also they have workplace stress. Most of them have a target. They work under the target. Therefore, sometimes they have stress, workplace stress, dangerous situation, other and lead to mental health issues. And also we identify menstrual hygiene, the reproductive concern and issues. Also the relationship issues. Less time for their well-being. You know, the most of the workers have to work 6 days per week. Only they have Sunday for off day, and they have no time to enjoy their life and get any health service from. And unmet need contraceptive. And also teenage pregnancies, unintended pregnancies can be seen. Also, we identify during our services, they have risky sexual behavior and the spread of HIV, STI. And most of the male workers, addiction to the drugs, alcoholism, and excessive social media also. Usage, unsafe abortion, this is unreported. Sri Lanka is abortion illegal, but there are reliable sources around the factory location. There are many clinics for giving those kind of services. Poor infrastructure and sexual exploitation management demand sexual bribe for promotion and money. That's also a very big issue among the factory workers. The LGBTIQ community is also confronted with the gender-based violence and sexual gender-based violence. As a right-based organization, as a Pan Association right-based SRH organization, we have objective to expand our service delivery point to the apparel sector. SRH knowledge combined with SRH clinical service position is the best way to address the SRH needs and challenges faced by apparel sector workers. As an SRH organization, Family Planning Association Sri Lanka identified this is as an emergent issue and as a strategy established service delivery point within the industrial zone to address these issues among the apparel sector workers. What strategies we follow to address these apparel sector workers? First, the first thing is we conduct a static clinic. Static clinic means center clinic. We have 3 service delivery points within the PTA zone. Each SDP conduct 2 static clinics per week, and also we have those 2 clinics as a flexible hours. You know, we have static clinic morning hours, early morning, and sometime after working hours. We conduct those 2 clinics. Then the factory women's and other male participants can participate the static clinic and get the health services. Then second, we use the second strategy, mobile health clinic. This is the very special program, mobile clinic, qualified service providers, including doctors, nurses, PHM, and MLT. We team go to the inside the factories and conduct mobile health clinic. Then the participant, that workers can participate while they work in the mobile clinic. This is the very famous health clinic among the factory workforce. And also we conduct associate clinic. Associate clinic, this is a new model. We provide all the factories, they are open medical centers, but they have limited staff. Through this associate clinic, we provide contraceptives to the health center. The health center staff distribute these contraceptives among the factory workers, and every month end they give the data to the Family Planning Association, our service delivery point. And we also conduct, as said India, we also conduct demand generation program. Why we conduct demand generation program? We need to increase the demand for SRH services. Through this demand generation program, we hold awareness session to raise the demand service. Workers participate in this session while working. They can participate in this demand generation program while they're working. This is not affected for their production. This is also a very famous program among the factory workers. We educated them a different SRH subject, and while we conducting those programs, we can provide them our services as well. And also we conduct as a special program in mobile exhibition. We have developed a special panels on SRH. We covered 7 SRH subjects through this mobile exhibition. We visit the factories and we display these exhibition panels at the canteen, some common places. And when they have free time, they come and read these panels and get some knowledge and ideas about the SRH. We also use the peer education model. In each factory, we identify few factory workers. Sometimes one factory in 3-4 factory workers, and we train them on SRH subject. And they visit to the factory and meet their colleagues and peers, and they disseminate the SRH knowledge. That's the peer education model. And also we recruit 3 counselors for our service delivery center, and we introduce a hotline service. We open this hotline service for 24 hours. Any factory workers can call and get any SRH information, and they can get any other services also through this hotline. And we, through this hotline, we disseminate SRH knowledge as a message among the factory workers. And also we conduct SRH awareness sessions, organize SRH awareness sessions through the various channels. That means various channels means sometimes we go to inside the factories and we provide, we do awareness sessions. Then while they're working, they can hear our SRH sessions. And after that, we give our centers information and our say numbers, and they can reach us anytime. And at the very beginning, we established the service delivery point. We had to conduct few advocacy programs because most of the factory management, especially the HR management, have negative feelings, negative attitudes on SRH and family planning. Therefore, we had to conduct few advocacy program for the targeting SRH, HR management and factory management. Through this advocacy program, we could create a positive environment to our services. Otherwise, they do not permit us to enter the factories and do our service provision and conduct any killing. Therefore, we had to conduct advocacy program. Advocacy program also one of our strategies to reach the factory workforce. And recently, under the Response project, we introduced telemedicine and telecounseling model also. By registering a local telemedicine platform, we give a dedicated numbers for that, and through that telemedicine and through that number, any workers can reach out our services. Anytime they can call and get information, they can get a prescription, and they can get other SRH services through this telemedicine and telecounseling. All factories share SRH management for GV screen and counseling and referral. We do when we conduct a mobile clinic, if we invite some workers to refer for other services, we have that referral mechanism as well. We refer to the clients in government, medical centers, and the private organizations. You can see this is awareness session at the workplace. While they work in, they listen to the SRH session. Also, we develop IC and BCC material. This is also help to disseminate the SRH knowledge among the factory workers. Also, Sri Lanka, under the CSC program, we identified a young workforce and we conduct CSC program. Under the CSC program, we cover 7 SRH subjects. This table, you can see that the number of SRH services for the last few years under these few strategies. In Koggala service delivery point, under the static clinic, we have provided around 100,000 SRH services. Under the mobile clinic, we provided around 57,000 SRH services. Under the associate clinic, we provided 6,568, and under the CBD program, community-based distributors, we use CBD as a PA educators use as a CBD. They bring contraceptives to the factories and distribute among the relevant target groups. Sitavaka service delivery we started last 2019. Under the static clinic, we could provide 36,196 services, and mobile clinic is a famous clinic for the clinic among the factory workers, and we could provide 63,471 services. Under the associate clinic, we could provide 5,548, and under the CBD and PA education model, we could provide 74,298. Watupitil is we established last year 2020. Watupitil was the recently established service delivery point. Under the Watupitil service delivery point, we could provide under the static clinic 8,000, around 8,000, and mobile clinic 31,000 around, and CBD 29,000 services. Here I illustrate the SRH services we offer. Through this, the above set strategies, we provide following type of SRH services, especially for family planning and contraceptives, and all gynecological services, and safe motherhood. We cover safe motherhood, including component of related to unwanted pregnancies and maternal health. And also we provide services sexually transmitted infection, including HIV/AIDS, and we do rapid test also. And if we need to for further service, we refer to the government STD clinic. Subfertility treatment and counseling we provide, and promotion for mental health and gender-based violence and psychological counseling and referral. And also we do well women clinic, and we conduct SRH awareness program and information. And all the service delivery point we have lab, and we do every lab test which relevant to the SRH, and we do general medical examination as well. Beneficiary for the workers. The workforce in the apparel industry adds value to each factory and keeping a beneficial to the factory in the long run. workers gain the following benefits from SRH service providing to them. Especially we educated them on SRH subject, likewise comprehensive SRH knowledge, including family planning, contraceptive method and STI, pregnancy, unwanted pregnancy, abortion, SRH challenges and risks, life skill and hygiene and sexual gender-based violence. They got all knowledge through this our program. Create positive behavior that will assist them in identifying risks and vulnerable situations, and they can deal with the sexual challenges positively. Improve an individual efficiency and productivity while they fostering mental integrity and mental ease. Motivating them to make informed decisions and positive decisions, reduce their vulnerability. And also manage their work and personal life to increase productivity and prepare them to cope with a variety of life situations and to gain confidence. Enhance job satisfaction and instill a positive attitude toward the workplace and improve positive health seeking behaviors and knowledge of personal health and health related products and services. The lessons learned during our service position and challenges we face. Access to SRH remains a challenge. I know that. And due to socio-cultural norms and in SR issues, in the Sri Lankan cultural context, it is very difficult to come forward and talk SR subject. 75% in the population comes under Sinhala Buddhist culture. They do not like to speak even word on SR subject. That is very big challenge. And factory management also have a negative attitude towards SRH subject, and to get approval for conduct any SRH program, it is very difficult, and they have less interest. They always think about the profit. They are profit-oriented company. Therefore, they do not like to give permission for our program. That is also a huge barrier for our program. And
Mr.
also,
sorry to come in. We have only 2 minutes left for the presentation, so
okay,
that we can have enough time for discussion.
I'll go quickly. Attending clinic during the working hours is a challenge. That's also now we are. That's why we conduct static clinic in flexible hours, morning and evening. Factory closed during the COVID-19. That is also badly affected our program service position, and so also the impact of social media. The future direction, we need to raise SRH awareness program among the factory workers through frequent program and advocacy program for factory management and decision makers for adoption policies and sales. We need to do some more advocacy program. That's also will help us to conduct our program in effective manner. Increase promotion of FSS, SRH services and SRH education program for target groups. That is my end. Thank you very much for your patience. Thank you very much.
Thank you so much, Mr. Rajapaksa, and my apologies for trying to. I thought it would be good to also spend some time in discussion on some of the things. Thank you for the fascinating presentation. I think I'll just request Amita and Dr. Nusrat to also switch on their videos and unmute themselves. I think it was actually quite interesting to see what were the commonalities in both the models. I think both of them were very same in trying to handle the services through a very prevention lens, then the service provision lens, awareness lens. So the entire continuum looked like that was being covered. And like I said, even after Amita's presentation, I think the COVID kind of disrupted the entire thing, and different kinds of models that were then taken up and adapted to, just to make sure that the services are not disrupted in a certain way, and how we can still cater to this unique population, because you could, even with both needs assessment in India as well as in Sri Lanka, it was quite clear that there is a lot of needs, SRHR needs, that are very unique to this population, and they're extremely vulnerable and marginalized in their own way. My first question is to Amita. I think this also takes us to the next session in the youth forum about engaging men and boys. I think you did highlight a feature about engaging men in this thing. What were some of the challenges that you felt, and do you think there have been some interesting strategies that you've adopted to get the men garment workers to be part of service delivery or awareness generation, considering they're a very hard to reach population in any case, even if not apparel workers? Yeah, please go ahead.
I just wanted to quickly share with you that the profile of the intervention that we did last year, that was in Bhimandi, which was a completely all male loom workers, right? As against what we are doing currently in Bangalore and Cholapur, which is a mixed group. However, I would say it's like 90% of the workers are women. So now when we were working in Bhimandi, their issues were primarily to do with STIs and HIV. And because, as I mentioned, if you all recall, that in Bhimandi, the brothel is right in the midst of where the loom workers, the factories are all placed. So, and typical profile of migrant workers away from their families. So there are easy access to the brothels. And so we saw huge amount of cases of STIs. Now there it was fairly simple because there was no inhibitions per se, and it was all men together. So they were able to express themselves. So that wasn't such a big problem in terms of SRH issues provision for them, because there were no women encroaching in, and they would get no scope for them to be embarrassed and to talk about and all of that. But when I'm talking about Bangalore and Sholapur, yes, it's a little tough, primarily because the men workers are less. And they are kind of, and when we are having these service sessions, while we try to maintain the maximum, I'm talking about when we provide services in the factories, while we do try and maintain confidentiality, privacy, at least audio visual, if not audio, at least, if not visual, at least audio privacy is to be maintained. But yet when we are seeing so many women standing or queuing to come for the services, the men refrain from standing in the queue with the women, right? So therefore, unless it's a very, if I can use the word non-threatening of a cough and a cold or a stomach ache or a headache, they are happy to come in. But when it comes to discussions about sexuality or, their SRH needs, it gets a little difficult. And therefore, we have kind of, if you remember, I had mentioned in the presentation that we are dedicating a specific day only for the male workers in our static clinic. FPI static clinic, maybe not in the shop floor, but in our static clinic, which is very close to where the factories are in Sholapur. That's one location. But for Bangalore, because apart from the fact that we have these service deliveries in the factories, we have also set up the Women Care Center. Now, by name itself, it's a women care center, so therefore the men shy away, but we are looking in terms of how we can dedicate a day there itself only for the men, or maybe once in 15 days, once in a month. We are toiling with those ideas, because we definitely do need to reach out to the men. So because we are fully cognizant of being, the need for SRS services for men, and we are doing all that we can. And as I mentioned that, COVID and telecounseling and teleconsultation services have really benefited the men as well. So they're able to freely express their issues, and they even something like, where do I access condoms from, right? So, and we are also, so far, we do not have too many male peer educators. We probably have, if I may be wrong, but I as far as my from the reports, I know that there are only about 6 male peer educators from a group of 67 that we have trained, right? So we would be increasing the male peer educators also, who are able to at least provide condoms to the men, or at least clarification, myths and misconception, because the men have a lot of clarification around sexuality issues, whether it's nightfall, all of that, so they need to be counseled on that. So we're trying to create a peer educators, more number of peer educators who can cater to the men and provide the SRH information and services. I hope I've been able to respond to your query.
No, absolutely, Amita. Absolutely, Amita. I think it is, as you yourself said, that it is extremely important, but the strategies that we need to employ to get men are sometimes quite different. I mean, my sense is that the fact that you've expanded the services and you're thinking about expanding it to NCDs and mental health may also facilitate that entry points for men, and then they can be. My next question is for Mr. Rajapaksha or Dr. Nusrat, whoever wants to take it. I think in the presentation, there was a highlight about, and even Amita had highlighted about presentation of digital modes and digital health interventions into the entire thing. So just wanted to understand some of your challenges that you faced and how did you ensure that, like, the interface was healthy and there was like, enough attention with the participation, considering some of the penetration for this might be low in this population. So any challenges that you faced, how did you go about mitigating that? It would be great to hear about digital health intervention, considering COVID has shown us that, like, maybe the movement towards digital health interventions need to be accelerated in a certain way, but it's easier said than done. And I think you guys are operationalizing it on the field. So I think it would be interesting to hear your thoughts on that. Dr. Nusrat, Mr. Rajapaksha, whoever wants to respond.
Yes, digital health intervention we recently introduced through our response project, and already we registered special dedicated numbers for, under that digital health intervention program. And I think Dr. Nusrat can add
Yes.
more than this. Yes, he is there. Yeah.
Yes, actually, hope I can be heard. Am I heard or am I audible?
Yes. Yes, please go ahead.
Already even before we started serving the zones, we already have a call center called the Happy Life Call Center, and plus also our STP supports hotline services through the STP managers. So those are already in place, which the services are offered through them. But the thing is, because you mentioned that ICT knowledge and the access to services in digital mode is a little bit of a challenge. So again, we thought of within the Respond project, we are planning to initiate a telemedicine platform as well, where we want to do a lot of promotional activities. And as Mr. Rajapaksa mentioned, Mr. Rajapaksa can add to more as well. Here, there are SRH messages are shared among the apparel work sector, where through they have televisions which runs in their canteen places where awareness raising programs are initiated, and also the phone numbers are shared there, and also through peer network also phone numbers are shared. So the phone is one thing they can access to us easily. The phones they don't have to directly connect to our Happy Life call center per se, which I'm going to discuss in my next presentation, which is with the DHI and other presentation. But they can directly link to their static clinic information center. Also, now we have given hotline services to our counselors who are within the static clinic. So we have 3 static clinics which are located within the apparel sectors, where any service workforce who wish to get those services can connect to these service providers as well. So we are planning to do a lot of promotional activities. As Mr. Rajapaksa mentioned, the telemedicine platform, which is a local platform, we want to register with them. And already it is quite popular in Sri Lanka, where they use this platform for telemedicine needs. So we are planning to register with them. So very soon we'll be doing that. We are already in discussion. We might do that. So that is one of the things that we are planning to do in future. Hope I have answered
Also,
your question.
Yeah.
Yes.
Also, we develop a WhatsApp group and we share message to WhatsApp group. All the factories covered through that WhatsApp group. And also we develop special video clips on SRH, and we stream those video clips at the canteen while they eating, and when they sitting at the canteen, they can see that video clips and on SRH. That also helps for us to disseminate the SRH message.
Thank you, Mr. Rajbaksha and Dr. Nujat. Certainly, I think that would be possibly ways to incorporate DHI models now, I think is way ahead for not only with April workers, but maybe also with young people and the other vulnerable populations, which have been which have different needs and are difficult to reach sometimes. One thing I think, Amita, there's a question that's appearing, which is about the fact that there was a second wave in India, and then the factories closed down, people went back, and I think you alluded about your things to the gendered norms that got even more entrenched. Now that the so-called economy is kind of there is a certain indication that it's opening up, and maybe the factory workers will be coming back. How do you think we will be able to build that momentum, which may have which we may have lost due to this factories closing down? Any particular strategies that you are planning to employ, or any ideas on that?
Yeah, so because one of the things that I have been discussing with the branches is that do we need to have a joint meeting of the factory managers, stroke owners, wherever is feasible, just to get them all together in, and I would say also to felicitate them that how they have managed to keep the factory running, and just give them an opportunity to talk about their challenges, right? So while of course I do understand factory managers is not we are supposed to be working with, but it's very important to get their buy-in and their support. So let them talk about what is their challenges, let them talk about what are they wanting to do for their workers. So this is one step that we thought. And of course, people are trickling back into the factories. But now, as we talk, I was just informed that in Maharashtra, the factories are now allowing full attendance, if I can say that, right? So earlier it was, only 50% capacity and all of that. Also, their export orders were facing a huge challenge. They were not able to meet their deadlines. So they are also in a hurry to, meet their commitments. So they are wanting the workers to come back. So we are going to be talking to them in terms, and this is something that we are planning in Cholapur is being planned, I think by the first week of December. So that we're trying to get their dates and all of that. So this is what we are planning, and we would be suggesting some things for the factory managers also to felicitate them, and also what the factory managers can do to motivate the workers. See, SRH will definitely happen once they have come back to normalcy. So we don't want to lose that touch with them, and they are merely because, though of course work is going on, but it is kind of people are trickling in, and the very little that we can really do about that. But people are coming back now. So that's my first step that I had planned, was to have a meeting with the factory managers to let them talk about their issues and what they want to do to motivate the workers. And of course, we'll be there with them all the way through.
Sure.
And
Thanks.
then, yeah.
Thanks, Amita. I think this question is valid for even FPA Sri Lanka, in terms of what are these advocacy touch points with the factory workers that you think that add to the add to the success, or maybe that's the important bit that in your experience that you could use. And unfortunately, we're just 1 minute into left with the time, so maybe but let's hear that from you, because you implement it on the ground. So it would be nice, and then we can close the session. Over to you, Dr. Nujrat and Mr. Rajapaksha. Your thinking on these touch points with factory owners and things which help the entry points to work in these really difficult situations.
Actually, Ms. Rajapaksa will be able to better answer this. It is an ongoing thing, Dr. Vikas. We've been doing that continuously. Mr. Rajapaksa and the team often meets the the management team of apparel sectors. So there's the awareness raising among the importance of SRH needs in these factories. So that is how we got the 3 zones. We were able to implement or initiate our SDP clinics within these 3 zones. And furthermore, there is a massive service gaps that was realized at the beginning, where the Ministry of Health is already serving most of the areas, entire Sri Lanka, through their grassroots systems. So there is a service gap for factory workers. So that is why we chose this free trade zone to serve, because our whole motive is to serve the underserved. So these gaps were chosen already pre-identified. And it's a continuous, the advocacy is continuous with the managerial team. And Mr. Rajapaksa, I think recently also you conducted a managerial advocacy program. Even virtually, they have done a couple of programs under certain projects also. So we are, it's a continuous program. Even though we are already established in 3 zones, still it is an area we are looking at, and we want to make it improve furthermore. As he said, there are a lot of negative attitudes towards SRH service delivery. So there is the key area where we are looking at. And thank you for Amitaji, your experience, what you shared. So we might consider those factors as well when it comes to implementation.
Oh.
Great. Thank you so much. I think we've unfortunately come to the end. There's so many questions still lined up, but please feel free to, I would request all the audience to send their questions to Saro Forum 2021, and whatever we can reach out to all the speakers and be able to answer. I think we would be happy to do that. Thank you so much, Mr. Rajapaksha, Dr. Nujrat, Amita, for this exciting presentation, and thank you for all the audience who've taken part in the thing. We invite everybody to the other sessions that will soon start in 5 minutes. So we will be, means I'm part of another session, which is also really interesting on engaging men and boys. And I think Amita's thing about how boys
I would have loved to be a part of that as well.
Great.
I just okay, yeah. Anyway.
No issues. No, thank you so much.
Thank you so
have
much.
a great
Thank
day.
you, thank you, thank you.
Bye
Thank you, Vikas. Thank you, Mr. Rajapaksha.
Thank you very much.
Thank you so much. Then.
Thanks. Bye-bye.
Have a great
Thank
day.
you.
Bye.